Okay, good morning. Can you guys hear me?
Good
Yes,
morning,
good
Dr.
morning.
Best. Yeah.
Hi, thank you. Just want to share my screen. Why don't we give it just a few extra moments?
Dr. Pass, we're seeing the presenter view.
Oh, thank you. Thank you very much. Figure out how to get out of that. Okay. I think this may work better. Is that better?
Yes.
Ah, good. Thank you. Just a moment. I see a picture of Neha's finger. Now she's blacked out.
Morning, Dr. Bass.
Good morning, Neha. Okay. Dr. Lozano, where are you from? Thank you for the good morning. Where are you joining us from? Just out of curiosity.
Mexico, doctor.
Ah, very nice. Where in Mexico?
Guadalajara, Jalisco.
Ah, nice to meet you. Thank you.
Nice to meet you too. Nice to meet you,
Guadalajara.
everybody.
Cool. Okay, let's give it another minute and then we'll get going. I see someone named Dr. Jandu. Where are you from, sir?
I'm from Baltimore, Maryland.
Ah, you sound like a woman, so I apologize for calling you sir. Okay. All right. Why don't we get going? This may be somewhat abbreviated, but hopefully not too bad. So today what I thought I would do is start by reviewing remote transmissions on devices. So this is something that the fellows, you guys don't get to see very often, but I spend a lot of time looking at remote monitoring. So as you know, when we put a pacemaker in people or a defibrillator, we monitor these patients going forward. And Grace, why do you think we monitor them? What's the concern? What kinds of things do we worry about when we put a pacemaker in somebody?
You worry about the battery life,
Yes, that's true. Okay.
and the mode in which they're pacing. You would also evaluate.
Well, I mean, the mode in which they're pacing, presumably you've chosen, so you know what that mode, you know what that is, right?
Yes. I guess the percentage of time that they're requiring pacing.
Yeah, that's true. What else can pacemakers tell us?
Their underlying rhythm.
Well,
it gives you an idea.
It gives you an idea, but in theory, if someone's in heart block and you're pacing them, you're not going to see their underlying rhythm.
Yeah.
But the other thing, I guess the thing I would say is, you know, when we think about pacemakers, the most important, shall we say, weak link in a pacemaker is the lead. The lead is always the problem. It's the vexing problem of all pacing systems. And so as an electrophysiologist caring for people with defibrillators or pacemakers, our number 1, 2, 3, 4, 5, 6, and 7 concern is the status of the leads, because leads always can break, and the survival of leads is a very serious concern, particularly in pediatric patients, because we use a lot of epicardial leads. Can you comment on what the difference in longevity is between an epicardial versus an endocardial lead, Grace?
You're suggesting, I think just the way you spoke about it, you suggest that epicardial leads don't last as long. But to be honest, I won't know for sure.
That's true, actually. Epicardial leads in general are much more fragile than endocardial leads. So that is the reason why we would always prefer in the right-sized patient that a patient get a transvenous lead, because epicardial leads are much more fragile. The bipolar, so traditionally the only epicardial leads that existed were so-called screw-in electrodes, which are literally as it sounds. It had a screw on the end, and the surgeon would just screw it into the epicardium. Those leads had very high failure rates. They developed a lot of high thresholds, or what we would sometimes call exit block. And as a result, Medtronic in the I guess I would say in the late 1990s and early 2000s, developed these steroid-eluting epicardial leads, which have become the standard because they're the only leads that have even reasonable longevity. And these leads have to be sewn onto the surface of the heart, and they come in both a unipolar and a bipolar modality. And these have markedly improved by epicardial pacing. But even using these excellent, somewhat more novel leads, the survival rate of these leads is still not outstanding. And so one of the most important things that we're checking in between in hospital evaluations is, as you suggested, the battery and the rhythm, but we're also most importantly checking the leads to make sure that the leads are functioning properly and that there's no evidence of a potential impending problem with the leads. We would obviously like to be proactive and aware of problems with our leads before they actually occur. So let me give you an example here. This is a patient of mine who did a download just in the last week or two. So this is a patient with a complete heart block who also has hypertrophic cardiomyopathy. And so she has a dual chamber pacemaker defibrillator. And so just remember, of course, all defibrillators are pacemakers. So you don't really have to say the words pacemaker defibrillator, but I'm just saying that for clarity this morning. But this is, so this is what we get. And I just thought it would be advantageous for us to review it just so you have an idea of what it is that we can see remotely. So when a person does a download, most companies like Medtronic or Boston Scientific have their own websites. And when we put a device in, sort of built into the price of the device is the ability to do this type of remote monitoring of the devices. And so so in the past, the patient would have a box that they would plug in their room. In the past, it had to be plugged into a phone line. Today, most of them have their own cell network. So they're essentially like expensive cell phones. And the patient would take a device off of this that looked like a mouse of a computer, put it over their device, press a button, and it would transmit information from the device. Today, most devices are wireless, and the patient actually doesn't have to do anything. And so what happens is we program remotely on the website how frequently we want a report to be sent to us. And typically it's quarterly. And basically at 2 in the morning on that date, it will communicate wirelessly to the pacemaker or the defibrillator and send us a report. Additionally, these devices are monitoring the patient in real time every day. And if they notice an irregularity, specifically a change in the impedance of any of the leads, it will also send a report automatically in most cases. So it's really quite remarkable. And this device has to be, I think, in most cases, about 10 feet or less from the patient's bed. So usually we'll say put it on your night table or on a shelf in your bedroom or under your bed, just so that it's close enough so that the patient can have communication. So let's see what it looks like. So this particular patient has both an atrial and a ventricular lead. So first thing we're seeing here is what they would refer to as the presenting electrogram. And so here is the electrogram 1, which is the atrial lead, A-tip to ring, which just means that between the electrodes on the distal tip of the pacing catheter. And we see here a large atrial electrogram, and then we see this small far field ventricular electrogram. And we've discussed in the past that when you put a catheter in the right atrial appendage, because the appendage flops over and sometimes is very close to the right ventricular outflow tract, it's not uncommon to have a small far field ventricular electrogram on the atrial electrogram. That's why there's this little thing that looks almost like a T wave, but it's, as you can see, it's simultaneous with the QRS. This is, and then it gives you a series of different electrograms. Let's go down to the third one here, electrogram 3. This is RV tip to ring. This is what is recorded between the two electrical electrodes at the tip of the lead. And we see here a nice large ventricular electrogram for every QRS. Okay, so you can see here's the A in our atrial and here's the V. And you can see that there is an artifact related to the T wave. So when programming this device, it's important to make sure that the sensitivity is not too high, or else you might double count this artifact here. And you can see it gives you actually a scale of 1 millivolt. So just eyeballing this, we can see that the RV electrogram is at least, I would say, 12.5 or even 15 millivolts. So that's good, right? We always want the electrogram, particularly in a defibrillator, to be very large. And the reason we want it to be large is because if the patient is in tachycardia, we want it to be able to see what's going on. And so the larger the electrogram, the more likely the device will be to see all arrhythmias at all times. Now, in this second electrogram, they're giving us another option to look at it between the coil, which is the shocking coil on the defibrillator lead, and the can. And the can means the device itself. So this is an electrogram that the device is creating between the RV coil, which is behind the two electrograms, and the can. So it's sort of like a unipolar signal. And we see it also because the coil is sitting in the right ventricle. We also have a large ventricular electrogram as well. And then they're giving us even another electrogram between the device and the ring of the atrial lead for another electrogram. And this is, all of these are useful because as you do as you do from download to download to download, it's sometimes useful to compare the electrograms. This is another way for us to confirm that the lead is stable, because it should look relatively similar every time you do this type of test. So they're giving us essentially 2 ways to look at the atrial electrogram and 2 ways to look at the ventricular electrogram. And here you can see that they're measuring the intervals between the beats, and you see that we are in ascents V-paced rhythm, which you would expect in someone who's in complete heart block. Okay, so let's go to the next slide. Okay. So the next page is where we get all of the information about the device. So first off, as Grace said, we're interested in the battery. And so we see here that we are told the remaining longevity. In this particular case, the device is estimating about 5 more years of longevity. And we see that with this device, I implanted in 2017. So in theory, then that means that if this is correct, the device will last approximately 8 years, which is, I would say, about average these days for a defibrillator, especially one that's pacing essentially 100% of the time. So we can see here the impedance to pacing in both the atrial and the ventricular leads. And this can be compared from download to download in order to confirm that. And what does the pace impedance tell us? Sergey, do you have any idea what is the pacing impedance giving us an idea about in regards to pacing leads?
No idea.
Okay, I like that, a man who tells the truth. So the pacing impedance is a measurement of usually of the integrity of the insulation of the lead. When the lead insulation is injured, which is almost always a precursor to the lead failing, we will see marked changes either up or down depending on what the problem is with it. And so what we like to see is that the pace impedance is not changing very much over time. And by not much, I would say usually within 50 to 100 ohms, it shouldn't really change from measurement to measurement. And so by seeing that the pace impedance is stable, we are indirectly knowing that the patient has stable leads, that nothing is happening in a bad way towards the leads. The next thing you see on that list is the defibrillation impedance, which in this case is 93 ohms. And every single defibrillator lead has a range of defibrillation impedance that is considered acceptable. In this case, this is on the high side, but it is still an acceptable shocking impedance. And so that is an indication that the coil, which is used for shocking, and the lead in terms of its shocking ability is intact, at least according to these measurements. In this particular case, I have capture threshold off. Does anybody know what capture threshold is? Let me ask Perna. Are you familiar with that term, or do you know what that means?
No, Dr. Pat.
Okay, so capture threshold is a system where the pacemaker can actually measure the threshold from beat to beat and adjust the output accordingly. And the theoretical benefit of this is that, normally when we program a pacemaker permanently, we set the outputs at roughly double the threshold. And as you know, the threshold is how much energy is required to pace the heart. But if you have capture management on, or capture threshold, then what the device can do is measure it and raise the output even much less than double. It could set it like, let's say, 1/4 of a volt above it, or 1/2 a volt above it instead of double. And theoretically, that could save battery life over the course of the device. Generally, I don't usually turn that on because in most patients, if the lead has good low thresholds, the amount of benefit or savings is fairly minimal from turning that feature on. So here we see how the patient is programmed. In this case, in the atrial lead, the patient is programmed at 1.75 volts in 0.5 milliseconds. Anything under 2 volts is a very low output, and here in the ventricle, 2 volts in 0.4 milliseconds. The device will measure the P wave and the R wave for us. So in this case, the P wave is 1.6 millivolts. Really, anything over 1 is considered a good P wave for an atrial lead. And for an R wave, the minimum accepted R wave is generally considered to be 4 millivolts. So this is not the largest R wave I've ever seen. And in fact, it is a little bit discrepant with what we just measured. Remember that on this page, we measured an R wave. If a box is 1 millivolt, then theoretically, this should be larger than that. So I'm not sure how this measurement was attained. And then this is the sensitivity that we've set. Here is the mode that the patient is on. So if somebody is looking at this remotely, or if you're on call and someone does a download and you have to look at it quickly, you can see how the patient is programmed. In this case, the patient is programmed DDD with a minimum rate of 50 and upper tracking rate of 145. And here are the paced and sensed AV intervals corresponding to the PR interval. And then here we can see how I have programmed the pacemaker. And so essentially, what I have basically told the device is that if the rate in the atrium or in the ventricle exceeds 200 beats per minute, I wanted to monitor it, which means I wanted to record it, but not deliver any therapy. You see, it says here, all therapy is off. But if the patient's heart rate exceeds 207 beats per minute, the device will try anti-tachycardia pacing, which is where the device will try to pace terminate the tachycardia. And it does that while it's charging. And if it doesn't work, it will shock the patient with 35 joules up to 6 times. Okay. And you can see there are different zones. There's a fast VT and a VT zone. So for example, in older patients, sometimes you can have slower forms of VT, which are still very hemodynamically embarrassing, but you wouldn't want to shock someone necessarily immediately for a VT at a rate of 140. So for example, in an adult older patient, an adult electrophysiologist might say, allow the heart rate to be 140 for 30 seconds, and if it doesn't terminate, then to deliver a shock. And you can program stuff like that on defibrillators. If we move on to the bottom here, we see here that the device has recorded 2 episodes where for greater than 4 beats, the heart rate was over 207 beats per minute. And so that's nice. And it's showing us that a defibrillator is a wonderful event recorder. And we can program it to record at basically any event that we want it to. And in this case, it's going to record any heart rate that exceeded 207. And we'll see if there's any more information in this report regarding these two episodes. Excuse me. When we come down to the bottom, we can see how much the patient is pacing. So we see here that 99.9% of the time, the patient is V-paced. And in fact, 99.3% of that is A-sense V-paced. What that means then is that if we look up here, I've set the lower rate at 50, meaning I've told the pacemaker, never let the rate go below 50 beats per minute. But the fact that the device is saying that she's A-sense V-paced at 99.3% of the time, what that means, of course, is that 99.3% of the time, her rate is over 50 because the lower rate is set at 50. If she went below 50, she would be A-pace V-paced. And we see that there is basically none of that. Okay, so her atrial rate is always a little higher than that. So right off on the first page, you could see a tremendous amount of information that we're getting from these downloads. And you should understand that this is a relatively new technology. It didn't exist even 10 years ago. And so in the past, we would just tell patients with defibrillators to come into the hospital every 3 months for an ICD check in the office. But now we can remotely get all of this great information remotely. It's quite extraordinary. Especially in the time of telehealth, it's pretty nice. Here we see that she's A-pace, V-pace, 0.6% of the time. So less than 1% of the time was her sinus rate going to be below 50 beats per minute. Now, we talked earlier that the device demonstrated 2 episodes of VT with heart rates that exceeded 207. Again, I'll show you here. You see here, there's these 2 episodes here. So now the device is going to show us these episodes, which is really pretty nice. So you see here, this is the electrogram that presented that, you know, when the patient did the check. But let's look at so if I zoom in, it's going to show us these 2 episodes, which is really quite remarkable. And so in this diagram, which I find a little confusing, the V to V rate is measured in milliseconds and is denoted with a dot, and the A to A an open box. And what we see here is the atrial and the ventricular rate are all the same, and you see that the cycle length is 600. So Perna, what is that heart rate if the patient was initially in cycle length 600?
I'm sorry, I was muted. 60,000 divided by
600.
600 will be 100.
Right. So the patient is presumably in sinus rhythm at 100. And then we see here that the ventricular rate, we see all these dark dots denoting V to V intervals, but the atrial dots stay up at the 600. So the atrium and the ventricle are at different rates. And in fact, we see that the ventricular rate is much faster, right? The cycle length or the R to R interval is below 300 milliseconds. And so this would suggest, right, if you have more V's than A's, then you're either a jet or VT. And since jet is really not seen in 20-year-old hypertrophs, this is an example of VT. And in fact, the device is giving us the electrogram, what it saw when the patient was in tachycardia. And in fact, what we see here is that the atrial rate continues at about 100 beats per minute, but the ventricular rate is at about 214 beats per minute. And we see here 1, 2, 3, 4, 5, 6. So this is a short run of non-sustained ventricular tachycardia that the device has recorded. Now, because the way that defibrillators work is that you can tell the device how long do you want to watch the VT before the device starts to charge. And so in most patients, what I normally ask is 1 or 2 seconds. But then the device has to charge, and it normally takes a defibrillator anywhere between 8 and 15 seconds to charge. And then usually it will recheck for approximately 1 more second before it defibrillates. And so we would not have expected that the device would have shocked her for this episode. But this is useful information because we're learning from this that the patient is having non-sustained ventricular tachycardia episodes. And we know, particularly in hypertrophic cardiomyopathy, that non-sustained VT on a Halter, and this is essentially the equivalent of a Halter, is a predictor of sudden cardiac death. And so this is a sign that the patient probably is, it's a good thing that there's a defibrillator in her. And that happened on June 25th. And then we see on June 16th, a very similar event. We see, if we look at this tracing, that the ventricular rate is getting, the cycle length is getting shorter and shorter, meaning the heart rate is getting faster and faster, but the atrial rate is not changing at all. And here we see 1, 2, 3, 4, 5, 6 beats of VT, and we clearly see that the ventricular rate is much faster than the atrial rate, which is like at 120 or 110. And in fact, it's telling us the atrial rate is the average heart rate beats per minute in the A and the V. Atrial rate's 111, ventricular rate is 231. So this is also an example of non-sustained ventricular tachycardia, which self-terminated. So as you can see, tremendous amount of information that we're getting from these downloads that could be very useful. If now in this particular patient, these were both asymptomatic episodes, and so we didn't do anything based on this observation. But I will tell you that the reason she has a defibrillator is because when she had just a pacemaker, we identified on a similar monitor a number of these episodes of VT. And it was this observation that occasioned the upgrade of her device to a dual chamber defibrillator from a pacemaker. So, so as you can see, we really get a lot of information from these downloads, and it's worth just sort of knowing what this is. And the way that we run it in our clinic, and it's done this way in most places, is somebody, in our case, Josie O'Toole, who's the nurse practitioner, obviously works with us. Josie checks this every single day, Monday through Friday, and is reviewing to see if there have been any uploads. And she will review all of them and make sure there's no concerning observations. If there are, she'll let me know. She'll say, you know, so-and-so had VT, or I'm concerned about the lead, and then we'll try and go back and look at the older downloads or the in-office check. Now, the only thing that this type of testing cannot do that we could do in the office is it can't check a threshold. And so that's another way to determine that the lead is stable. It's a very good way. And so that's one of the reasons that we like patients to come in, obviously, to be evaluated in the office. And so our general practice is to see patients twice a year in the office for a real visit, and for them to do these remote checks, which are going on automatically. And the other thing about these is if the patient is ever concerned about anything, they can command the device at home to do a download. The only bad thing about this is that we don't get any notification from the company in the event that there's a problem. In other words, the information is all there, but because there's not a live person on the other end, we have to check it, or else we won't know it's there. So what we normally tell patients is that in regards to their routine checks, no news is good news. We don't usually call them if the device is working adequately and properly, and they should just be aware that it's happening in the background. But if they do a download because they're concerned about something, then we will typically ask them to call us and say, you know, I'm worried about this, there was a download. So when you're on call as the cardiology fellow, on rare occasions, someone's going to call in and say, you know, I have a defibrillator, I just fainted, can you check this? This happened just a few weeks ago. There was a patient of mine who has a subcutaneous ICD, and she woke up on the ground in her kitchen, not knowing what had happened, and was taken by ambulance to a hospital and was determined to have had a successful shock for VF. You might ask the question, why did she not do a download? The answer is that her model of SICD, which was the first form of subcutaneous ICD that was ever developed, does not allow for remote monitoring. And so she had to go to the emergency room. I'm glad she did. I would have advised that she do that anyway for a first shock. And she was observed overnight and went home. But the point is that most of the time, because of this wonderful technology, we can remotely monitor these patients. For certain devices, particularly for pacemakers, but I think even now ICDs, depending on the company, there's even an app on their phone. So for Medtronic, for example, this is all done through an app on the phone. So basically the phone is the transmitter, and the device will communicate with the phone, and then the phone will send the transmission. So really extraordinary technology, and I just wanted you to be able to see what it is that we're doing. And you know, with our practice, I bet you Josie reviews over 20 of these every single week. Okay. So this is an example of a child who had a heart transplant 10 years earlier. So the question is, what is the rhythm? What is the treatment? And what workup should be done? So I think I'm going to hit up David Barris.
Good morning, Dr. Pass.
How
I'm just
are you?
I'm doing well, thanks. Just looking at our rate over here first, and I see a little bit more than 2 boxes between our RR. So give me around 100 and maybe 130 beats per minute. So then in terms of our rhythm, which I guess is the name of the game here, looking for P waves, in lead 1, lead 2, lead AVF, having some trouble appreciating it in lead 2. The QRS does look a little bit, just a little bit wider than typical, almost with an upslope. If there had been a P wave, I would maybe even call it like a pre-excitation, but I'm not really appreciating one. I'm looking now at V1 just to see if I could try to appreciate one hidden.
Yep.
I do see maybe a little notch in the end of the T wave.
Yep.
So perhaps there's some sort of retrograde P wave over there.
Why are you saying how do you know it's retrograde?
Just I guess
just
I
because it's
definitively
closer to the last QRS than the next QRS? Is that?
Again, that's what I would assume, but perhaps assume incorrectly.
Yes, I was watching an episode of The Odd Couple the other day where Felix said that when you assume, you make an ass out of you and me.
Yeah, I've heard that line.
One of the great stupid lines of television. Well, it's a good assumption, actually, but it is, in this particular case, it's wrong. Now, if you look in AVL, I think you're right, David. There is, in fact, a P wave that is on the end of the T wave. It's subtle. But I think if you look also in lead 1, there's a suggestion of that, although again, this is a very subtle finding, but this is where having the entire EKG is helpful because you're looking for clues. This also is probably a P wave on the end of a T wave here. And of course, the easiest way to know that is to look at an old EKG of the patient. I'm not showing you it, but suffice it to say, this little inflection was not there on the old electrocardiogram. So if this is, in fact, it's a P wave, and if this is a P wave, I think you would agree that they're upright in 1 and F. It's hard to say for sure. So then what would you, if that is, so that would suggest maybe it's a sinus P wave. So what would you say then is going on if that is a sinus P wave?
So it could be, we have a very long PR interval, first degree block.
Right.
That's
right. That is in fact what this is. So this is, sort of sinus tachycardia, right? It's a little bit of a fast rate for a resting EKG. And it's first degree heart block. So let's say for the sake of this discussion, which is true, that this patient did not have this observation on prior EKGs. And as you know, our heart transplant patients are seen very, very frequently. They must get, I make this number up, 200 EKGs in their lifetime or more. So what would you be thinking if you had so you have a patient who's not feeling well, is in the emergency department, she had a heart transplant, and this is the finding that the patient has. What would you be concerned about anything?
I mean, I know that myocarditis can prolong the PR interval, possibly rejection. Maybe I'd be concerned about as well in this patient.
So rejection is always in the differential in any transplant patient who has any EKG abnormality. That's always the right answer. That'll always be correct 100% credit. So rejection can cause any arrhythmias. Usually, in my experience, rejection causes tachyarrhythmias. So you'll see an EAT or something along those lines. So you could argue that maybe this isn't sinus and this is some kind of ectopic atrial tachycardia near to the sinus node that's causing a P wave similar to the sinus, and it could be an EAT from rejection. Is there anything else that we would worry about in a transplant patient?
Medication side effects.
Okay, I don't think any of the anti-rejection therapies cause this type of observation, but she could be on something else. Maybe she's on amiodarone and is hypothyroid, which can cause this, but she's not. Let me ask Jenna. Jenna, do you have any other thoughts on anything else you might be concerned about in somebody with a tracing like this in a transplant patient? I figure she comes from a large heart transplant program.
Sorry. So as David was answering it, the rejection was the first thing also to pop into my mind.
Again, a very good answer.
Mm-hmm.
Get 100% credit for that, David and Jenna. But any other possibilities, though?
I mean, it could also be, something that could happen to anyone. So she could have Lyme's disease that could be causing a PR prolongation like this.
Yeah, so she could have Lyme disease or myocarditis or hypothyroidism, yes, but that's certainly true. They're human beings also. So we'll give you 100% credit for that. I'll accept that as an answer as well. But what about any other things specific to transplant that we ought to be worried about? And we're 10 years out from transplant, and we're seeing this. All right, I'll just answer it.
Yes. Oh, can I?
Please,
so
please.
If she has any type of like coronary vasculopathy.
Yes, coronary vasculopathy, very important consideration. So patients after heart transplant can develop coronary disease. In fact, they routinely develop coronary disease, and that is in fact why, of course, we do what is sometimes referred to as the annual, and the annual usually involves is a catheterization in which we do a biopsy and measure the hemodynamics, but we also shoot the coronaries. Now, some centers have moved away from that and do other type of imaging, but I think the standard approach is to do coronaries every year. And of course, we're doing that because we are worried about the possibility of coronary vasculopathy. And the longer you are out from transplant, the greater your risk is for that. There are theories about why people get it. Do you have any idea, Jenna, why it's believed that people can get, what contributes, I should say, to coronary vasculopathy? Are there any risk factors?
Obviously, it's the further out, I think, from the transplant, the higher
That's
risk
certainly
over
true.
time.
Yep.
I'm not sure if it has to do with if you get a what's the word I'm looking for, like a matched transplant.
That's interesting. So
I'm
really,
sure.
the other two are viral infections. So I believe that there is some belief that, or some data to suggest that if you're sort of chronically have EBV, as you know, there are some of these transplant patients who will develop viral infections because of their immunosuppression, and also because they may have a donor that has EBV or or CMV. Right, CMV is a serious concern in a transplanted patient, and they will almost always accept a CMV positive donor into a CMV negative recipient, but that carries its own risks, and there are ways of managing that. But if a person has a chronic viral infection, that can do it. And then I believe the most important risk factor is episodes of rejection. So people who aren't compliant with their medicine and and have a lot of episodes of rejection requiring acute therapy with steroids or escalation of their anti-rejection therapy, they are also at risk. This patient early on in their treatment was very non-compliant with their medications, had a lot of episodes of rejection. And in fact, this patient had a coronary problem. And this was the only sign. So, Sergey, if somebody was having coronary ischemia to a degree that caused first-degree heart block, I'll ask you two questions. One, which coronary do you think is affected? And two, if they're having coronary ischemia, why are they not complaining of chest pain?
I would think it's left coronary artery, the answer to the first question. And the second is that, well, the transplanted heart is denervated, so they don't feel the pain.
That's right. So I'll give you 50% on those answers. That's true. Usually a transplant patient does not feel chest pain. It's not impossible. There is some evidence for renervation over time, but you cannot use the absence of chest pain in a transplant patient as equal to not having ischemia. So the absence of chest pain is a useless symptom to ask in this group. I mean, you always would check and ask, but the absence of it is unfortunately not a reassuring observation. And actually, most of the time, I believe 3/4 of patients' AV nodes are actually perfused from their right coronary. So if you're going to statistically guess, the more likely thing is that there's a right coronary problem. And in fact, when we cath this patient, we did observe very severe stenosis of the distal right coronary. And unfortunately, it's not, it's very hard to manage this. This is usually a very bad sign. And this patient actually did die about 2 to 3 years after this was first observed, unfortunately, tragically. Okay. Let's see here. This is a surveillance Halter. This is just something that was seen on Halter. So I see Dr. Alawalia there, who's been working like a maniac all weekend, taking good care of all of our inpatients and allowing me to sleep during the evening. Thank you, Neha. What would you say is going on here in this tracing?
So the first beat looks like a sinus beat, PQRS with a narrow QRS. And then the subsequent beat, you see the QRS widens. Don't know if that's actually a P wave or not, but doesn't matter. The rate is...
It's very hard to tell because I
right.
gave you such a shitty tracing. But let's just say for the sake of discussion that the rate is, I don't know, let's say it's 100.
Yeah. And looks like the rate doesn't change. Again, it's hard to say, but it's not that fast.
Mm-hmm.
It's similar. And then at the end of the tracing, again, you have sinus beats. So I would say this is, I mean, you're concerned about VT, but the rate is not that high, is not that significantly faster.
So how would you describe this if you were writing a Halter report? You're the interpreter this week for Halters. How would you describe what you saw here? So I agree, on the left-hand side, there's clearly a sinus beat. And on the right-hand side, there's clearly 2 sinus beats. So
Right.
how would you describe this? I agree. This is not VT, but how would we call this?
Accelerated ventricular
Yeah.
rhythm.
So you would say there are periods of accelerated ventricular rhythm at rates similar to the sinus rate. It's almost like competing. So we talked a few weeks ago when I gave my general EP talk about the fact that when it comes to the rhythm of the heart, whatever is fastest always wins. And so here we are in an accelerated ventricular rhythm. Let's say this is at a rate of 100. I think it's clear that these two sinus beats are much tighter together than these. So as soon as the sinus rate accelerated above the accelerated ventricular rhythm rate, the VT, or the accelerated ventricular rhythm, was extinguished and the patient was in sinus rhythm. So we would just call this sinus rhythm with periods of accelerated ventricular rhythm. All right, it's 7:45. I think we're going to stop here. We have our case management thing in 15 minutes. Thank you very much for joining me, and we'll see you in just a few minutes. Okay. Any
Thank you.
questions?
Thank you.
No, we're good. Okay. Have a great day, everybody.